A very good morning to all of you, and we are going to start this session, which is on. Please come, Dr. Jagrati. We are going to start this session on keratoconus, which is something, a disease, which a mysterious disease, I would say, because it does have its own issues in terms of understanding the earliest cases, in terms of yeah, in terms of managing these cases appropriately. And we'll be discussing some pertinent issues. And we all know that cross linking has now become a very an established modality of treatment. So, the question is that whether any patient who comes to you for keratoconus, with keratoconus, should we cross link all the patients? The answer is with Dr. Vijay Sharma, and he will be discussing this question, that whether all keratoconic corneas should be cross-linked or we have to select patients to cross-link. Dr. Vijay, please.
Thank you, sir. So, my topic is, should all keratoconic corneas be cross-linked? Now, starting with a historical perspective about collagen cross-linking, it was Wolensek et al. In 2003 who were working at Technical University of Dresden, where they first time described the collagen cross-linking. That's why the conventional protocol came to be known as Dresden protocol. Uh, Basically, riboflavin saturated cornea is irradiated with the ultraviolet A radiation of 370 nanometer, and it increases the cross linking between the adjacent collagen fibrils, which increases the biomechanical strength of the cornea, and also it stops the progression of corneal ectasia. So, if we see what are the indications at present, so the indications are can be divided into ectasias and non-ectasias. Ectasias include primary ectasias such as keratoconus and pellucid marginal degenerations, and secondary ectasias such as post-Lacy ectasia. In non-ectatic disorder, the collagen cross-linking is being done for infectious keratitis, as in PAX-CXL, bullous keratopathy, chemical injuries, and even Terrien marginal degenerations. In keratoconus, how we progress, how we go ahead and decide for keratoconus collagen cross linking. In adults, it's recommended that you should document the progression for the keratoconus, whereas in children usually the progression is very fast and you do not wait, and you can plan for collagen cross linking without waiting or documenting for progression. If the corneal thickness is more than 400, you go ahead with the isosmolar collagen cross linking. If corneal thickness is between 330 to 400 micron, you can go ahead with a hyposmolar collagen cross linking. Also, you can, if you want to improve the visual acuity in addition by use of eximers, then you can go ahead with a PRK and CXL as in topo-guided removal of epithelium in keratoconus. And also you can follow up you can go ahead with the PTK and CXL as in Creighton protocol. You can also combine CXL with the intracorneal ring segments as well as eye track in addition to this. And also you can go ahead with the customized cross-linking. So these are the various protocols at present where the collagen cross-linking you can do in keratoconus. Another important criteria is we have discussed the corneal thickness and age. Another important thing is the progression, as we have to document in the adults. Now, how do you go ahead with the what are the various criterias? Now, criterias have been changing over a period of time. In 2003, Dresden, they took as an increase of K max by more than 1 diopter, and patient self-reporting deterioration of visual acuity and also need of contact lens fitting more than once in 2 years. Whereas then they kept on changing slightly, and last recommended was Gomes et al. In 2015, who said that progressive steepening of the anterior corneal surface, progressive steepening of the posterior corneal surface, and progressive thinning. And they did not give any specific values because these values are specific to specific instruments. So, in addition, there are some cases where perceived risk of progression is high, then documentation may not be required, and you can go ahead straight away with the collagen cross linking in those cases. I'll not go in detail in the protocols because these will be covered in subsequent lectures. There you'll see which one is better, and should we go for a standard or a accelerated protocol. Do we have any role of supplemental oxygen or pulsing of the UV radiations? How will that affect the collagen cross-linking? Also, the iontophoresis. Iontophoresis, I have no first-hand experience as such, but what has been described is single cycle or a double cycle CXL iontophoresis can be done. In single cycle, electrode is placed over the cornea and a forehead, and 5 milliampere per 5 minutes is the current that is passed. It increases the penetration of riboflavin into cornea with epithelium on, and in double cycle it is the 10 milliampere per 10 minute which is passed, and then collagen cross linking can be done. These are some of the contraindications if the patient is having any herpetic ocular infection, if there are any concurrent ocular infections or neurotrophic keratitis, poor epithelial wound healing, severe dry eyes, autoimmune disorders in pregnancy, you should avoid doing cross linking, or you should be careful, take all the precautions. What if collagen cross linking fails? Any criteria for repeat collagen cross linking? There are few studies which have been published. If the previous collagen cross linking has been done at least 6 months earlier, and there is increase of Kmax by more than 1 diopter, and the increase of manifest cylinder by more than 1 diopter, that has been taken in most of these studies as a criteria for progression of keratoconus after collagen cross linking. And usually these are the children who are having the allergic conjunctivitis, frequent eye rubbing, and pre-op Kmax value more than 58 diopters, and paracentral cone, who are more likely to require the repeat collagen cross linking. And when to do which technique, still there is no consensus as such, but you can take your preferred technique in these. What if there is no documented progression? As you know, if the other eye has healed hydrops and this eye has a keratoconus, you should go ahead with a collagen cross-linking in this eye to increase the biomechanical strength. Similarly, if the pachymetry is approaching your cutoff values, and then you can go ahead with the cross-linking without documenting the progression in these adult patients. In this, you can see the thinnest package is around 355. So you should not wait for 6 months and wait for the corneal thickness to become even lower, and then it goes out of the your collagen cross-linking perspective. Now, in this case, you can still wait. There is sufficient time, so documentation can be done. So, thank you.
Thank you, Dr. Vijay. Actually, this is a big question. Actually, we keep thinking about whether any patient who has come to us, whether we should cross-link or not. So somehow I feel that maybe somebody who is, say, uh, 15, 16, 18 years of age, having a significant keratoconus, has come to you without an evidence of progression, but still having a thickness of, say, 435 or 438, something like that. This means it is progressing.
Yes.
So then in that case, instead of waiting, if we wait, then we won't be able to do isoosmolar. We will have to do hypo, and we all know that hypo has lesser effect than the conventional isoosmolar. So in such cases, maybe I would even ask the panelists what they think. I would feel that even in the first sitting, if the patient comes without an evidence of progression, then also we can do it.
Yes.
But somebody who is, say, 30 years of age and coming with about 450 and all that, so maybe we can just see and observe. This is one practical thing which I normally follow. Any opinion on that?
Yeah, I think the same also holds depending on the loss of lines the patient already has. So if it is, a high astigmatism with an okay cornea and maybe 6/6 vision, you can wait a bit more than, let's say, with 6/18 and like Dr. Rajesh just mentioned, all the other criteria.
Yes.
So maybe you really don't need to document progression in that case.
Yes.
Yeah, I agree with you. Like, because if as they say, we don't treat the laboratory and the investigations, we actually treat the patient. So if the patient is having good vision and is comfortable, we can actually maybe we can have a shorter follow-up than usual and keep checking on them.
Please take the mic, sir, right behind you.
Can't hear you.
Right there.
Basically, the keratoconus is not a visual threatening, it's a visual disturbance disease. And Professor Sinha long back gave us a lecture in Kashmir. It's a form of a corneal degeneration, which is a non-inflammatory corneal dysplasia. You have a base and apex of the cone, which is corresponding to polycapic cornea. And a lot of modalities which we have, contact lens, then cross-corneal linkage, stromal, drawing, and others. But at the end of the day, one thing, very important thing is, we should sort of see what are the medical and the ocular manifestations which are associated with keratoconus. Like we have to see that it's not a Marfan's, Montevallo syndrome, like Turner's, Dons, SLE, achondroplasia. I've seen a case of achondroplasia in Middle East, a short person with a mental retardation, his mental okay was all right, he has a bilateral keratoconus. It was published in Saudi Medical Journal. Similarly, you have got ocular conditions like congenital cataract, aniridia. You have got congenital nevus amaurosis, other conditions besides RP, that have to be kept into consideration. Thank you very much.
Thank you, sir. So now we proceed to another aspect of now whatever you've learned about when to manage keratoconus, on how to manage it. And Dr. Rajesh Sinha will be talking about cross-linking in thin cornea and the newer modality of oxygen supplementation for the same purpose.
Thank you very much. And basically, cross-linking now is an established modality. There's no doubt about it. The only issue is that if the cornea is thinner than 400 microns, then there will be a risk of damaging the endothelium by UV rays. So, how to protect it? What to do in thin corneas? That is the issue when we think and discuss about cross-linking in thin corneas. So various methods have been employed. Like long back, Farhad Hafizi group, they suggested hypoosmolar riboflavin, that is in 0.1% riboflavin in 0.9% saline instead of dextran. And what it does, it swells up the cornea, and that is how the distance of UV rays which is falling on the corneal surface to the endothelium, that distance increases, and that's how they protected the endothelium. This was the theory. Then people have used bandage contact lens in order to increase the gap. People have used SMILE lenticule. People have also done transepithelial CXL in corneas which are 410, 405 or 400 microns, so that they can maintain that 400 thickness. So all these modalities have been tried. So as far as hypo CXL is concerned, it has been done initially. When it came into practice, there was some good outcome that they noted. And Farhad Hafizi was the one who first brought it, and he showed that it is free of endothelial toxicity. Now the question is that if you are swelling the cornea and you are protecting the endothelium, but in cross-linking you are making it compact. So these are two paradoxical things, and that is why studies have shown that when you compare the conventional versus hypoosmolar cross-linking, the effect is not as good as conventional. So that is one issue. However, having said that, in thin corneas, there is some effect that is seen in with hypoosmolar CXL, but definitely not as great as conventional cross-linking. Then another report, another method proposed from this part of the country only, and it was by Susan Jacob. They used contact lens, bandage contact lens to increase the separation of UV rays from the endothelium. Well, again, the safety is there because you are increasing the gap, but the efficacy will not be there. Why? Because first of all, we all know that cross-linking works mostly in anterior two-thirds of cornea, and part of it is being occupied by the bandage contact lens and the precorneal tear film between the contact lens and the cornea. So that will be discarded. So the effect will not be that great. That is one. Point number two, it has been noted that because of the precorneal tear film, the tear film between the contact lens and the cornea, the penetration of UV is not very good. So that is again a reason why it is again not being practiced so much. Then people have used SMILE lenticule to put over the cornea so that the precordial tear film is not there, it is in direct contact. Again, the effect will not be as good as conventional cross-linking. And as I said, somebody who is having a corneal thickness of close to, say, 400 microns, you have a margin of 400 microns, so you can do a transepithelial, but it is known that transepithelial is not as effective as epi of cross-linking. And people have tried various methodologies. They have done partial removal of epithelium, and in those cases, they found out that the demarcation line was not visible in the area where epithelium was present. So in thin corneas, we planned a study wherein corneas wherein the thickness was less than 400 microns, we created intrastromal pocket with femtosecond laser, infused riboflavin in the pocket, and used a negative meniscus lenticule. How we created negative meniscus lenticule? We took a donor lenticule of 200 microns, ablated the central part of the lenticule, central 4 millimeter, and then for 75 microns, and that is how we created that lenticule. So the idea was to increase the bulk, provide biomechanical strength, some arc shortening effect because of the negative meniscus lenticule, and central flattening as well. And this was the idea, and this is how we did. So we used the femtosecond laser to create the pocket, and once the pocket was created, it was dissected, and after dissecting, riboflavin was infused into the pocket. So when you infuse riboflavin into the pocket, the penetration is very fast, both posteriorly as well as anteriorly. So in 2 minutes time, it will penetrate and it will get into the stroma completely. And then a lenticule, a negative meniscus lenticule created from a donor lenticule which was again put on riboflavin for 2 minutes. It was introduced into the corneal stroma. So this is how we do it. It is introduced into the stroma, and then it is spread all around and then we check with the slit beam whether there is any fold in the lenticule or not. And once it is done, then we keep putting riboflavin, and then we do cross-linking over it. And we do accelerated cross-linking, 9 milliwatt per centimeter square for 10 minutes. On day one, you see that the lenticule is quite thick because of obvious reasons, but at 6 months' time, you see the lenticule reduces. And over time, what we have seen that this lenticule thickness reduces, and the central part, we normally take 200 microns of lenticule, ablate the central part by 75 microns. So we have about 125 microns left. And on day one, obviously, it swells up quite a lot. But at 6 months, this 125 microns, it reduces down to close to the average that we had in our study was 89 microns. So somebody who is having a corneal thickness of, say, 350 microns, increases down to up to 440. You have done cross-linking. So you have increased the tectonic strength. You have cross-linked the cornea, so you have stiffened it, and then these patients can be visually rehabilitated by RGP contact lens, mostly mini-scleral contact lens, and it works for the rest of their life. The issue here is that, see, this is the post-op picture, but we don't see such clean picture in all. Why? It happened in the initial cases, because we thought that we just have to give steroid for a short period of 6 weeks or 8 weeks. What we found out was there was interface haze. There were 2 interfaces and there was interface haze. So then we started putting the patient on steroid for longer period, and now we give about 6 to 8 months time, we give topical steroid, and you can get a pristine clear cornea like this. The tectonic strength increases. Another thing that I would like to mention here is that when we started doing it, we created a lenticule, we created a pocket of 7.8 millimeter, which was the maximum that we could do with the VisuMax machine. I don't have any financial interest. Later on, we thought that, in keratoconus, even if you do a lambda graft, you need to do a large. If you are putting a intrastromal lenticule, that also needs to be large. Why? Because the peripheral thicker part was coming over the cone, and that was creating more problems. So we increased the size of the lenticule to 8.5. and that is working well. So 9 millimeter pocket with with a femtosecond laser and 8.5 millimeter lenticule, and that gives you a very nice picture. This is one of the cases wherein the astigmatism reduced down. There is an arc shortening effect as well, and the astigmatism reduced down. See, here it is 6 diopters. It reduced down to 1.5 diopters, almost 1 diopter. You may not get the same in all cases. You may still have astigmatism. But if you have a pristine clear cornea, you have a good tectonic strength. Just one last issue that I would like to mention here is that for thin corneas, adaptive fluence has been described by Farhad Hafizi group. However, what they have done is that this sub 400 protocol allows for treatment of corneas as thin as 214 microns, and they described that no cornea showed endothelial decompensation, but they did not evaluate the endothelial status. They just evaluated the endothelial status by seeing whether there was any corneal decompensation. We all know that these patients are young, they have a very high endothelial density. So even if there is a significant loss of endothelium, there will not be corneal decompensation. So there's a lot of fallacy in this study, and perhaps with time we will be able to know. Just one last thing, as I was mentioning, that in thin cornea, somebody who's having a 400 microns thickness, one may think of doing a trans-epi, but trans-epi as such has less effect, and a lot of studies was being done these days. Animal studies have shown that oxygen supplemented cross-linking may have a better effect. We also did a study in keratoconic eyes of more than 400 microns. There was, I'm not going to mention all that in this presentation, but just a brief, I will tell you that what we found out that Kmax reduction was more in oxygen supplemented. However, the astigmatism reduction was not that much. The Kmax and Kmin both reduced significantly, but the astigmatism reduction was not that much. So whether it will have so much of clinical significance, it is still difficult to say. I'm doing 3 such studies these days, and you some of the findings. Now this is the goggles. The goggles that was available was costing us 300 euros. So we made a goggle with the PPE kit normally that we used in our during our COVID period. So we created an opening in the center for the UV rays to pass, and we connected one side to the oxygen supplier, and the rate of oxygen supply was 5 liters per minute. And we also tried to measure the oxygen concentration in the periocular field. And this is how it was done. Riboflavin was also put through the opening that was above, and this line is showing that it is going to the anesthesia machine, and it shows the concentration of the oxygen in the periocular field, and you can see it's 84%. We saw that the flattening, the Kmax reduces significantly, but in thin corneas, in corneas wherein the thickness is around 400 microns, we compared EP on with oxygen supplementation and EP off, and we found out that EP off hypoosmolar fared better. So in conclusion, as has already been mentioned, cross-linking is aimed to increase the tectonic strength of the cornea. It brings about some degree of flattening. If we use these intrastomal lenticule, with time we'll be in a position to titrate the morphology of the lenticule as well, in order to provide better refractive outcome. But as of now, it provides good tectonic strength and enables us to use contact lens and defer keratoplasty for perhaps the rest of the life. Thank you very much for your patient listening.
Thank you, Dr. Rajesh. It's nice to hear, innovations about all these methods from you, each new session that you have been conducting on the same topic for a long time. So I had a question. When you are creating a femtosecond pocket in a compromised cornea, does that weaken the cornea a bit, though I know you're inserting a lenticule there?
Sorry, your question.
Yeah, you're creating a femtosecond pocket in a keratoconic cornea.
True.
So, and that's a flat pocket, unlike what you do for ICRS, which is restricted to the periphery. So, are you in any way decreasing the tensile strength of the
No,
cornea
it
slightly
does not.
further?
It increases actually the tensile strength. The reason is this, that we are introducing a lenticule. It provides tectonic strength, and we are cross-linking as well. So that way it works very well. And so far, what we have seen is that the effect of cross-linking is also very good. The riboflavin penetration is fast when we are putting it in the pocket, and it works quite well. The only issue that we have so far noticed is that in after we have started using topical steroid for about 6 to 8 months time, there is hardly any interface haze. But still, one-off case, sometimes we do get interface haze, and that is one issue which we have to keep working on. Some other factors, maybe these cases have more inflammation in the eye. That is something that we have to rule out. Maybe we have to start steroid preoperatively. So these questions are there, but most of the cases are doing well, and we prescribe miniscleral contact lens in these cases, and they are doing quite well so far. I think it's almost 2 years now. We started it during the COVID period. But it's almost 2 years now, and most of the cases are doing quite well. Yes, there is chance of rejection. I completely agree with you. But stromal rejections are very minimal, very less, very insignificant. When you talk about the endothelial rejection, the risk is higher. But stromal rejections are very minimal. That we have noted in DALC also, wherein we give so much of stromal thickness, still the rejection is less. So the risk of rejection is there, and in case there is a rejection, we can always do a DALC in these cases. But in large majority, in vast majority, you can just manage with this minimally invasive procedure, and the patient can be happy for the rest of the life.
And one last question. So you said the stromal thickness, the thickness of the lenticule decreases from 125 microns to around 89, 90
Yeah,
microns. So that's over a period of 2 years, I assume.
That
is that over a period
of 1 year.
Okay. So what
Mostly-
happens later on?
See, mostly the thinning happens in the initial part only. But subsequently also there can be some little bit of thinning, but that will not be that much significant. So even if somebody is having, say, 350 microns cornea and it reduces down to 89, so it will be 440. And in subsequent years, even if it reduces, it will come down to 430, 425, something like that. So it will be above 400. So patient can be managed well. One-off case, if it further goes down, but still managing well with contact lens, that also can be done. So, I mean, it's not something which is going to be a complete, it will completely remove the requirement of keratoplasty, but yes, it can differ in large majority of cases. It can reduce the requirement of keratoplasty in large number of cases.
And maybe help the patient cross that period of activity, like, reach that age when naturally the progression of keratoconus
And even if you do keratoplasty, say if you do DALC, you put 16 sutures, rehabilitation requires so much of long period. There are all sorts of risk of suture related thing. And further, I would like to say that this is not a replacement for DALC. This is something which is a modality which can help in large majority of keratoconic corneas. But in DALC, you can manage even when there is a central scar. Here, we should not use when there is a central scar. So the indications may differ, but yes, it's a good modality in a large number of cases.
Maybe, as you said, it facilitates doing the cross-linking in thin corneas by supplementing that.
True,
So
true.
both the selections would be different as in DALK and in this
Absolutely.
the case selection.
Yeah.
And would there be a little concern about leaving some riboflavin in the pocket? Because when it's used on the surface, that usually gets washed off at the end.
Yeah.
But the riboflavin which
Well,
was
yes.
used intrastromally,
Yeah, but that gets absorbed in the stroma. As such, also you want the riboflavin to get absorbed. It acts as a photosensitizer. So there should be a pooling kind of a thing. But when you are putting a lenticule, there won't be any pooling. There may be a layer, and that also will get absorbed in the stroma. And that's what you want when you're doing cross-linking.
so possibly the wait time between the installation of riboflavin intrastromally and using the light as such for doing the cross-linking, could that be increased to keep this pull getting absorbed more, or that? Would there be a difference if some more time is given for that?
That we maybe, I mean,
Maybe
we
you can add to your
yeah, maybe we
dimension to
can
your
just
study.
see the regarding the duration, whether with the duration gap is
Would
going to
help or
change
not.
any outcome. That we don't know. But
And
yeah.
in addition to that, did you see any haze coming after the initial clearing in any of the patients?
In one case, yes.
Okay.
And that was actually this patient, this haze came late, and we managed with steroid. Little bit of trace is still there, but yes, but that was seen in one case.
So could
And
that
we also
be-
had one case of CMV keratitis also in these cases. So I mean, all these things are possibility. Patient needs to come for regular follow-up. That's important.
And regarding the stromal leaving of riboflavin in the pocket, that was already done when we were doing LASIK extra. So yeah, we always, so that just
So we
diffuses.
want that to get absorbed only. So it's there, it will get absorbed. Yes, sir. Yes, sir. No, not endophthalmitis. I had one case of keratitis wherein I had to remove the lenticule. No significant glare, halo dry eye. The problem in initial cases was a little bit, yes, as you said, in lenticule, wherein we were putting a smaller lenticule of 7 millimeter. In some cases, we did have a little bit of issue, but after starting 8.5 millimeter lenticule, things are a lot better. So now we move on to our next talk, and that is by Dr. Swapna Nair, and she will be talking about how does intracorneal ring segment help, when to do, type of ICRS, and in which cases.
Thank you, Dr. Rajesh, for having me here. ICRS is another form of treatment for keratoconic eyes, where you try to provide some amount of visual rehabilitation also. So, as we know that myopic LASIK, it removes central corneal tissue, and by the same mechanism, adding tissue to the periphery, as is done using ICRS, also corrects myopia to some extent. Now, besides correction of myopia, there is also some space creation between the corneal lamellae in the periphery, which leads to a shortening of the central arc length of the cornea. And this causes a redistribution of the stress. Now, this was studied by El Husseini in 2013. And they found out that this redistribution of stress, it changes the disease course to some extent. So these are the two mechanisms, and these are two basic facts on which application of ICRS depends. So ICRS is inserted in the posterior stroma, being less compact than the anterior. And now there are two factors here: the diameter of the ring and the thickness of the ring. So diameter of the ring means the circle from which that ring arc is made. So the shorter the diameter, the higher amount of myopia that is treated. So it's and secondly, the more of dioptric correction is treated, provided you put a thicker ring. So the rings I usually use are the Intacs, and that varies in thickness from 0.21 millimeters to 450 microns. So depending on what amount of correction you need, you can increase the thickness or reduce the diameter. Now, basically, when there is loss of lines due to corneal change, or you have a high dioptric corneal value, with a central clear cornea and a minimal pachymetry of 450 microns at the point where you want to insert the ring segments are the indications for the condition but for this procedure. And these are the various conditions in which you can use. So basically for ectasia without central scarring and with a minimal residual corneal thickness. Now, you won't do the procedure in corneal scars or dystrophies or when you have recurrent corneal erosions in pregnancy, any sort of autoimmune diseases and drugs that affect the cornea. Also, you have to be careful when you are doing this in patients with large pupils and with a lot of eye rubbing that is likely to cause a rapid progression of the basic disease itself and with low endothelial cell counts because we are dealing with the posterior cornea over here. So now there are different types of intracorneal ring segments, namely Intacs, the Ferrara rings, Garo rings, Mayo ring. So Intacs have an arc of 150 degrees. They're hexagonal in cross section. The later ones also are oval in cross section. You have two types: the standard ones that are used for smaller dioptric powers, and the steep K ones which are used for higher dioptric powers in the range of around 57 diopters of corneal steepening or more. So there you have a shorter diameter than the standard ones because we saw that a smaller diameter corrects more of myopia and flattens the cornea more. So the Ferrara rings are again PMMA ones but with a triangular cross section. And they basically have a height of the triangle and a base of the triangle, the base being 600 to 800 microns and the height is on which the correction depends. The Kera rings are similar to the Ferrara rings, though they have two extra segments. The Mayo ring is a completely circular, a donut-shaped ring that can be inserted in a corneal pocket, and it has an upper convex and a lower flat surface. Now, coming to the insertion of Ferrara rings, this is a manual dissection of the cornea for insertion of the intracorneal ring segments. So you can see that a vertical cut is made to define the pockets through which the ring has to pass. And the pockets are taken completely circular, and then you can insert either one or two rings of the same dimensions or different dimensions depending on how symmetrical the cornea is. So if you have a decentered cone or an asymmetrical astigmatism, then you may suffice with insertion of one ring. But if you have a very symmetrical central cone, you may need two rings of nearly the same dimensions to flatten that. So here you see that once the pocket has been made, a ring is being inserted. So here you have a pre-existing dissected pocket into which the ring is inserted. Now here is the pocket for the Mayo ring. So either using a dissector or the femtosecond LASIK, you can create a pocket of around 9 millimeters at 300 microns into the cornea. And then the Mayo ring is placed centered on the pupil. So this being having a convex surface on top and a flat surface at the bottom, again stretches the cornea centrally, decreasing the arc length and therefore correcting the amount of myopia. Intacs, either you marker there. So I use a Sinskey hook or the end tip of a chopper to just put the mark over there. Is achieved. The pocket for the Intacs are made very fast because the laser fires simultaneously in a ring manner, and then it creates a central cut. Now this vertical cut happens along the portion where the positive astigmatism happens. So this is the axis of positive astigmatism where you start inserting the rings or the point of the vertical cut. So then now these pockets are latent pockets that are made by the femtosecond LASIK. So you start dissecting them first just to create two entry points Then you start inserting the rings, and it is using these rings that the rest of the pocket is dissected. So you don't need a separate dissection for that. And depending on, like I said, the centration of the cone and steepness of the cone, you can insert symmetrical segments or asymmetrical segments. Now, once they're inserted, you have to make sure that the end of the segment is about 1 millimeter inside the pocket so that it doesn't extrude spontaneously. Another caution that is used to make sure that there is no spontaneous extrusion is insertion of a suture at the vertical cut that was made initially. So now this is there are various nomograms for to know what kind of ring has to be used and how you have to place and number of rings. So this is the latest one given by Addition Technology. There's one described by Dr. Rohit Shetty that was quite some time back in 2014. So that was a good way of using the rings. Now this is the one that has been provided by the company, and you can get it from the website. Now basic rules of planning I've already mentioned as I was showing the videos. So if you have a central myopic cone, try to put symmetric segments. If you have high astigmatic components, asymmetric segments, and a highly decentered oval cone, even a single inferior segment will do. And when you're dealing with highly asymmetric cornea, you can have a thin segment superiorly and a thicker segment inferiorly. Now, here another point to note is that the mid-peripheral pachy in the region of 6 millimeters from the center of the 3 millimeters from the center of the cornea is what is most important. So, even if you have a low central pachy, if your mid-peripheral thickness is well built and quite good, then you can insert intact. So, you have to take an entire pachymetry map on, and not just the central thickness of the cornea. That it has beautiful topographic and visual results. There's fast rehabilitation, and you can reduce a lot of myopia and astigmatism using this. And now with the SK segments, you can go even further with higher diopter corrections. So this is how the post-operative picture looks, and you can see how the segments rest in the posterior part of the stroma. And you can always offer an additional treatment for this. So like, CXL or ICL. Now, you have to be aware of the complications, though I have done it for around 7 years now, and I haven't faced any personal ones, but superficial protrusion of the rings, especially in vigorous eye rubbers, extrusion of the rings or exposure of the rings can happen. On the other hand, if you've gone too deep or you have not assessed the mid-peripheral thickness properly, you can have an AC perforation. Then, of course, there are some deposits that may form around the rings that I have seen, though it is not very common, but some sort of white flakes that may form at the edge of the tunnel. Infectious keratitis in any pocket is a reality. Then there could be persistent corneal edema around the segments. And these are some of the factors, if going to the extreme end, may require explantation of the rings. These are the various studies, I know it's a busy slide, that have tested the efficacy and the safety of the segments. And these are the multiple combinations that can be used along with these segments to provide correction of the basic condition as well as visual rehabilitation. Thank you very much.
Thank you, Dr. Swapna. Can you keep the questions at the end so that we'll now have Dr. Namrata Sharma with more details on the cross-linking aspects, types of riboflavin, and the current status of accelerated cross-linking. We can take a quick question if there is one while the setup is being done. We can go ahead.
One question from me, ma'am. What would you like to prefer for improvement in visual acuity? Is it using a intracorneal ring segments or using a PRK along with CXL?
Again, it depends on the amount of correction you need to improve the visual acuity. We know that in keratoconic cornea, it is not very easy or to take a decision on whether to do PRK, even if there is an added CXL to it. And when the dioptric correction is large, or even with PRK, we can just assume that we are, regularizing the cornea rather than treating the dioptric correction. So if you want to treat a large dioptric correction, I definitely would recommend ICRS. And if the correction is very small and you can do with just regularizing some amount of the cornea, then maybe PRK.
So thank you. I would be talking to you about types of riboflavin and current status of accelerated cross-linking. Now, if you look at keratoconic cornea, important thing is that it does have reduced biomechanical stability, and when cross-linking is done, there is alteration in the pattern of the collagen. And corneal cross-linking does allow corneal stiffening by forming crosslinks, and I'm sure this has already been covered in the previous talks with 330% increase in the biomechanical resistance. Now, if you look at the basic structure of riboflavin, it is a photoactivated chromophore with absorption peak at 370 nanometers, large hydrophilic molecule, inadequate to penetrate through the intact corneal epithelium, and that's why it requires corneal deepithelialization so that the penetration increases. There are basically, if we look at the US FDA approved solutions, two of them. One is riboflavin 5-phosphate with dextran, and the other is riboflavin 5-phosphate 0.1%, or what we say as hypoosmolar, which is used for hypoosmolar collagen cross-linking. Now, if you look at the various riboflavins here, of course, this is a busy slide, but you have 0.1% riboflavin with dextran, then you have 0.1% riboflavin without dextran, then you have 0.25% riboflavin for transepithelial collagen cross-linking because the epithelium is not debrided, so the concentration is higher. Then riboflavin with HPMC because dextran causes thinning, and then same is used for other procedures when intrastromal applications are done. So dextran has osmotic effect, and that reduces the corneal thickness, and the HPMC base that way is better because it increases the diffusion rate and reduces the loading time. If you look at dextran versus HPMC based solutions, as far as the clinical outcomes are concerned, it is known that the one with the dextran have greater percentage of penetration, and so this is responsible for transient thinning. This is just to show the same from Peshke without any financial interest. So isoosmolar riboflavin is the one which is most commonly used with 20% dextran. Hypoosmolar, on the other hand, is 0.1% solution, and it is dextran free. Now, there are standard formulations which do not penetrate well. So in order to increase the penetration, you can use various agents like benzalkonium chloride, EDTA, vitamin E, TPGs, or iontophoresis can be done. People have used even oral riboflavin, but it has systemic side effects, so it is not currently in use. As far as the Dresden versus accelerated protocols are concerned, the classical Dresden protocol was when you used the UV radiation 3 milliwatt per centimeter square for 30 minutes. And accelerated protocol is eventually could be any one of the following. That means 6 milliwatt for 15 minutes, 9 milliwatt for 10 minutes, 15 milliwatts for 6 minutes, or 30 milliwatt for 3 minutes. Now, more than this, people have even done 40 milliwatts, but that they have not found it. 45 milliwatts, they have not found it to be efficacious. Now, this is as per the Bunsen-Roscoe law of reciprocity, where the total energy has to be 5.4 joules per centimeter square. There is a need for rapid protocols because for patient compliance, and also for the fact that if you have prolonged UV radiation, then there's prolonged dehydration, and that can lead to corneal thinning. So this is one study which looked at standard versus accelerated cross-linking, and in terms of efficacy and flattening, there was not too much of a difference, but demarcation line was more superficial in accelerated collagen cross-linking than in standard cross-linking. And this was a meta-analysis of 1,000 plus eyes, which favored accelerated cross-linking, except for the fact that the deeper demarcation line is present with the collagen cross-linking. This is again epi of standard versus accelerated cross-linking, which shows that there is no difference in the depth of the corneal stromal demarcation line between the two. Now, in pediatric eyes, also accelerated collagen cross-linking have been evaluated and are found to give good results. And here, Vibextra is used. That means the concentration of the riboflavin is increased because some people like to do transepithelial collagen cross-linking, especially in pediatric eyes. Now, accelerated collagen cross-linking can be pulsed or continuous, normal fluence or high fluence, pachymetry-based, photorefractive interstromal cross-linking, or LASIK extra can be done. So basically, the high fluence accelerated cross-linking causes significant epithelial remodeling, and there are hardly any changes in the thinnest pre-op areas, and it reduces the thickness variability from central 6 millimeters. And if you look at the epithelial modeling, then there's significant epithelial modeling, which is observed at 6 months, and this does improve the regularity. Now, this is a study which compared pulsed versus continuous accelerated collagen cross-linking, and pulse light allows optimized intraoperative oxygen availability, improving the post-op functional outcomes. And this is just to show the confocal picture of the same. And notice that with the pulse light, the demarcation line is clearer as opposed to with a continuous light. And with the pulse light, the apoptosis is also deeper and the demarcation line is also deeper. Now, this is the pachymetry based accelerated collagen cross-linking based on the M nomogram, which allows selection of the treatment protocol to achieve the desired cross-linking depth. And people have even done customized cross-linking, which is found to be safe and effective treatment for low grade of myopia. LASIK extra is, of course, when you combine LASIK with accelerated collagen cross-linking, and it is better both for refractive and keratometry stability, but there are no long-term results or randomized studies to prove the same. So these are the various studies of accelerated collagen cross-linking with good results. Flattening does occur, and pachymetry does reduce, at least in the initial post-op period. And there are several concerns, however. The concerns are the biomechanics, and because of the increased speed of the procedure, there is reduced time for oxygen diffusion, and this may create a hypoxic environment. And so, biomechanical effect of collagen cross-linking is oxygen dependent, and that is something which we need to know. Dr. Rajesh has done a wonderful study on the role of oxygen in collagen cross-linking, both in normal corneas and in thin corneas, and I'm sure he must have told you about the results. Now, there are limitations in the current literature because the progression criteria is a little different in various studies. Grading method severity is different. Riboflavin solution times are different. Concentrations are different, and the soaking time is also different. Also, the follow-up duration is not same for all studies. So, to conclude, accelerated collagen cross-linking is safe and allows corneal stiffening in cases of progressive keratoconus. There are variable results reported in different studies in terms of functional outcome, and it does show promising results, at least the short and the midterm, but long-term studies are required. So, recommendation is multicentric trials in the long-term studies, especially in high-risk group like children and syndromic associations. Thank you very much for your kind attention.
Thank you, ma'am. Any question or any point that?
Yeah, I have a question, ma'am. This regarding in children. So, have you found that you would need to add on another procedure for children? And if so, how long does the initial procedure last?
So we have done a study which has been published in American Journal of Ophthalmology in 116 patients with keratoconus, and we found that we had to repeat collagen cross-linking in 8% of the children. So the study that is published is 1 year now. These children have followed up close to 10 years now, and we do have to repeat, especially in case of children, and more so if they have vernal keratoconjunctivitis. So repeat collagen cross-linking is a reality.
And at what time? from the initial procedure?
So, if whenever, of course, you closely monitor them, and whenever you think that it has progressed, then you need to repeat it. Having said this, suppose initially they've undergone a accelerated collagen cross-linking, which was our protocol for children. We then, in a repeat procedure, try to do a conventional cross-linking.
And what's the youngest that you have done?
So the youngest we've done is 7-year-old.
Thank you.
Thank you, ma'am. And now we move on to the next talk, and that will be by Professor Arun Jain. And he'll be talking to us about whether contact lens is the mainstay of visual rehabilitation, and if it is, that what are the designs and how well we can improve the visual outcome by contact lenses in cases of keratoconus.
Sound is not okay. So thank you, Rajesh, for having me part of this wonderful instruction course, and I have been given the responsibility to justify that whether contact lenses are the mainstay of visual rehabilitation in keratoconus patients and various contact lens design. As we all know, way back in 1998, this study showed us that almost 75% of patients with keratoconus need some sort of contact lens, and only 10 to 20% need some surgical intervention. And of late now, only maybe 5 to 10% of keratoconus patients need surgical intervention. So, and also we know that at each stage of keratoconus, we have different options of treatment available to us. But whatever type of treatment you give to the patients, you have to visually rehabilitate this patient with some sort of optical correction, be it spectacle or contact lens, because the astigmatism in these cases highly irregular. It is usually not amenable to correction by spectacles. So almost all patients, even after doing some corneal surgical procedure, they will need some sort of optical correction in terms of spectacle and contact lens. This is a busy slide, so these are the various different types of soft, hybrid, piggyback. I won't go into detail all this. We will concentrate mainly onto the rigid lenses because they are the mainstay of treatment to counteract these astigmatism and minuscule or large scleral lenses, which where the keratoconus is very advanced and the cone is also very protruding. In those cases, large scleral lenses are indicated. So, depending upon the grade of keratoconus, whether the keratoconus is mild, moderate, or severe, depending on the K reading and the size, shape, and position of the cone, you will have to choose the contact lens. So, mainstay again, I'm emphasizing is the uh, rigid gas permeable lenses, which may be either in the form of rose K2 and different type of scleral contact lenses. So, depending upon the morphology of the keratoconus cone, you will decide which type of contact lens. If it is a small central nipple cone, it's easy to fit with a contact lens. But if the cone is little large and oval, it's more challenging to fit a contact lens in these cases. And if it is still large and involving almost whole of the cornea, it will typically warrant the use of scleral type of contact lenses. So diameter of the contact lens is based on the location of the cone, its size, and the steepness of the cornea. So soft toric, as I've already highlighted, they are easy to handle and they are comfortable, but they will work only in early keratoconus cases, and usually they drape over the corneal surface, so they won't correct high degree of astigmatic power. So indication will be only early keratoconus, RG or where RGBs are not tolerated, and spherical scleral contact lens have failed to mask the corneal astigmatism. So coming to the rigid gas permeable lenses, these are usually the first choice for correcting the irregular astigmatism and vision improvement, because in keratoconus what patient wants is stabilization of progression and the vision. These are the two main concern of from the patient's point of view. And nowadays very highly permeable, oxygen permeable lens materials are available. So they are not very expensive, though they are expensive, but not very expensive, and they give a very good vision. And if handled properly, they may last for at least 2 years. And but the downside is there is a little lower initial comfort, and but they are suitable for high corneal surrender and irregular cornea. And this is the latest classification given by the Scleral Lens Education Society, which is internationally recognized. And there is subdivision into the corneal type, corneal scleral, or full scleral lenses, depending upon the size of the contact lens and where they are resting. So scleral are further divided into smaller and large scleral lenses. So fitting keratoconus has been traditionally complicated. You need a lot of skill and experience. There are so many different types of designs and sets available, and a lot of sheer time is required. So you have to have a dedicated optometrist working with you. And rose K design is the most common lens prescribed for this type of keratoconus patients. And what is the special about it? It's a tri-curve lens. Standard lens have a very fixed optical zone, and they do not fit the cone shape of the keratoconus. And there is an unwanted pooling of the tear around the standard lenses. But these rose K lenses, they are tri-curve lenses, fits and snugly over to the cone of the keratoconus. And you have to have an optimal fit. And this has to be, I am not going into details of fitting philosophies, because that is a that will take a lecture in itself. So there should be a light feather touch in the at the apex of the cone is desired. So there should be no and mid peripheral bearing, as well as there the edge lift should be quite adequate in these cases. And this is a one representative case of 35-year-old male who had a high astigmatism of 5 diopter in both the eyes, and with spectacles she was only improving to 636 and 618. So this is the pentagam of the same patient. And this is the way you go about selecting the lens, the base curve, diameter, power, edge lift, design, material, tint, and with and without sort of exchange if the edge lift is more. So all these parameters has to be verified, and then you place a final lens order. This is how you record the findings on a paper. And this is the same patient with the contact lens, and there's an optimal central feather touch, and there's a mild pulling, mid peripheral bearing, and adequate edge lift in this case. And this is another case with the 6 diopter and of astigmatism. Other eye was correctable this was correctable to 6.6. And so these are again same parameters, but here the keratoconus is even more advanced, 11 diopter. This lens, this case was fitted from outside the ordinary lens. So what has happened is there is an apical bearing. Patient has developed apical scarring onto the cornea, and you can see it's a flat, and it leads to scarring on the cornea. So we changed it to rose K. So there is a minimal feather touch and a mid peripheral bearing and an edge lift. So the fitting of the contact lens is very important in this case. This is the first paper from India we published on rose K lenses, which is based on topographic finding. Even the inventor of rose K lens, he wrote to us that he really liked the paper. He's from New Zealand. And coming to the scleral, another 3-4 slides only. So as we already discussed, if the keratoconus is advanced, the cone is very large, we have to use these scleral type of contact lenses, but they are expensive. They do improve the vision drastically, but they are a little expensive, and the lens handling initially people find it difficult. And we have to know the lens anatomy. In these cases, there is a central clearance zone which should be clear of the cornea around 150 to 250. Then the independent limbal independent transfer zone offers independent customer. It has to be customized. So again, I am not going into the fitting philosophies. And this is the scleral landing zone, which aligns onto the sclera. So what we do is, when we are doing the assessment of these lenses, there should be optimal clearance, which should be around 100 to 300 micron, and it should be tapering. It should be tapering towards the periphery, and the edge lift has to be proper. There should be 50-50 rule should be followed. It should not be impinging too much onto the there should not be too much of edge lift, or there should not be digging in of the edge of the lenses that will compromise the ocular surface, as well as patient will have discomfort. So just example of this case, patient had -8, -6, 636, this is pentacam. So we fitted with the scleral lens. You can see the clearance on the OCT. CASA is quite helpful even in evaluating these cases. So you can see the fluorescent pattern which is tapering, and this is another case of again this thing. And even post keratoplasty, you have, if there is a very high astigmatism, you have to fit these cases. So the conclude, at whatever stage of keratoconus you are, there are different options. So in initial stages, you have the option of C3R. You have already heard all the speakers: phakic ICL, toric IOL, TPKR, and in the later stages, you have the option of lamellar or penetrating keratoplasty. But whatever you do, you have to give them a optical correction in the form of spectacle or contact lenses. And I do say that contact lenses are the mainstay of treatment as a supplement to the various therapies we give to the keratoconus at different stages of the treatment. Thank you so much.
Thank you, sir. Completely agree with your punchline that contact lens is the mainstay, and it will remain, I guess, till the time we find a solution to reverse keratoconus, because keratoconus results in irregularity of the cornea, and we have to mask it by use of keratoconus. In early cases, we may do all sorts of TCAT and CXL and all those things, and we can provide some refractive change as well, but in large majority, we do require contact lens to mask the irregularity. The biggest advantage of the last few years has been the popularity of the mini-scleral contact lenses, wherein even as a large cone, thin corneas of 250 microns, large cone, still you can manage with mini-scleral contact lens and defer the requirement of keratoplasty for years and years. However, in a few cases, in spite of whatever you do, CXL, contact lens, etc., you do require keratoplasty, and that's what Dr. Jagriti will be presenting, that when keratoplasty to be done in cases of keratoconus.
Thank you, Dr. Rajesh. Thank you for making me part of this in-depth discussion of all aspects of keratoconus, and such a relevant topic for all our clinical practices. Whether be it the cornea specialist or the general ophthalmologist, we all come across these cases every now and then. A very good morning to all of you. Thank you for being here. When should keratoplasty be done? We come to that aspect now. Well, progression, thinning, and bulging as it goes on, despite all the other modalities that have been used, will give us a significant distortion in the cornea and a blur which cannot be finally fully corrected with all the other means. So in these cases, advanced cases, the loss of the vision can be addressed with surgery. Majority of these cases which go into surgery, we will want to have a precise outline as to when to go for it, like especially when you are out of your training and all, there's always this dilemma: what would be the right time, or am I taking the right decision for my patient by subjecting them to surgery now? So there are no indices, metrics, or any of the features on say ASOCT or topography, because there's a poor correlation with the clinical effects, as in the patient's comfort and the patient's vision and day-to-day functional requirements. Yet, when do we consider surgery? It's when there is a very high regular astigmatism. There could be scarring, which could be primarily because of the keratoconus, or it could be secondary to hydrops. This leads to the functional loss of vision, which cannot be corrected adequately, or the other means like contact lens are now not tolerable. Visual excess is not spared. There is obscuration of the visual excess, or other means of halting the disease are now exhausted. You tried the other things, but still the visual requirement of the patient is not addressed. There has been a past episode of an unpleasant episode with the contact lens, or if we still want to go by the grading, if the stage 4 by AK classification, where the refraction is impossible, corneal diameter is very high, pachymetry is very low, and there are central scars. So for those of us who would like to have a definite flow chart of design as to this is to be done when this, then there is this criteria where you can look for a progressive disease, yes or no, and then the grades 1, 2, 3, 4, and accordingly the final thing on the chart would be the corneal transplantation when there would be a grade 4 or higher up. But then we can have surgery by choice also. If you are a very conservative person, or if the patient is conservative, have read up a lot and does not want to be subjected to the side effects or the adverse situations which come from the other modalities, very few of them would probably want it. Or when the surgeon is wary of the query effect of the ultraviolet light or the riboflavin and the combination on the stem cells. And of late, what has been reported has been the gross thinning of the cornea post 6 months to 2 years to 5 years of cross-linking, where you see a very thinned out cornea, a sort of absorption of the stroma post this. So classically, what type of surgery? It is penetrating keratoplasty, which used to give excellent optical results, and this was the best indication for getting the best outcomes in keratoplasty. But of now, DALK is the chosen one because we are going to spare the healthy endothelium of the patient. And for the other obvious advantage where the rejection will be less, it is not an open sky technique, there's a stronger eye, there's little work to do in the anterior chamber. No risk of rejection, there is less requirement of the steroids and the secondary risk of glaucoma. And it can be modified in different way if we have available femtosecond, that can also be used. And there are techniques where the bubbles are to be done, and it can be the different types, which is not in the scope of this discussion. But at the same time, despite all this done, and if you're going for surgery, you will want to keep the allergy in check. So many of the patients would have associated vernal keratoconjunctivitis. And if we don't keep this in check, probably only the period while the steroids are on, the patient might remain comfortable. But then the allergy, if it comes back, none of the other modalities are going to give you consistent result for a long time. And that too in after keratoplasty, that graft can also become ectatic if there is constant rubbing in the eye because of itching. So the different modalities which are required are shown in this flow chart and can be used in different combinations. But the mainstay would remain as allergen avoidance, a cold water lavage, cold compression, and mast cell stabilizing agent, which can be given for a long time after the surgery, along with the post-surgical treatment. If this is not checked, and if you're looking at the outcomes, these are a few photographs of this farinaceous keratopathy with this ropey discharge, this floor-like dusting on the surface. These are the cases which need to be looked into very carefully, because they would have this upper lids with large cobbles, and these are the patients who are likely to have such reactions, prolonged reactions in the sutures post-keratoplasty for keratoconus. And these need long-term steroids, and then later on, these patients do well on tacrolimus ointment also. So it would be nice to treat this preoperatively. So again, when keratoplasty, when this has been treated and taken care of, otherwise the surface would not be good enough to keep the sutures good. And once the sutures tend to loosen, you need to replace them. And there'll be, as shown here, there would be localized ectasias because of the loosening of the sutures, and this would again give irregular astigmatism. So the idea would be to have a block-to-block connection, but this is not how it is in keratoconus. Our cornea would be thinned out. So we would want to watch out to give this edge-to-edge connection and not a disparity on the surface. And thereby you get a regular surface like that. So to get a clear graft like this, it is important to look into these aspects beforehand. Supposedly, if you had a pre-operative keratoconus patient with scarring, yet a DAL can be attempted, there might be a bit of this residual scarring around it, or if on table during surgery you ended up with a small opening in the descemex, you can still go ahead with the surgery, because if this is off the excess, you will still get reasonably good visual outcomes. This scars remain at the edge and the visual excess is spared, so you still get reasonably good outcomes. To be a little more careful, we would want to avoid double chambers or a gap here. Here there is a little separation which leads to localized edema, which resolves on its own sometimes if it is small, or with a rebubble. There can be distortions like this in the graft, a torque-like effect which should be taken care of during surgery, so that again you don't get those irregularity. If these are in periphery, they don't really matter, but usually you can steam them out or roll them out in the central part. Of course, we would all be dreading this infections, and due care should be taken for that to get the good surgical outcome. Add-on surgeries would be required, as in when there's loose sutures, replacement of the sutures, or if there's an irregular astigmatism on healing, top-up surgeries for that can be required. Finally, to conclude, there should be no transplant done if myopia and astigmatism is correctable, optical aids are well tolerated and can be made tolerable, cornea is clear in the visual axis, there is no scarring, no edema, progression is under check with the other means which have already been discussed, and there is a monitored compliance for keeping the allergy quiet. So, and if this all is looked into, the vision would be good enough and keratoplasty would not be required. Thank you so much for the patient hearing.
Thank you, Dr. Jagriti. It was nice insight into when and how to do keratoplasty, what keratoplasty to be done. And just one last thing, if there's any question on this topic, do you have any? Yes, sir, please. Sir, we can't hear you, sir.
Sir,
We can't hear you, sir.
Please use the mic.
See, vernal keratoconjunctivitis is a very common thing. It was initially called as a spring catarrh. But you do have a corneal manifestation of spring catarrh, which is not dependent upon the conjunctivitis. It's called as a dystrophy. So, in this condition, you have a immediate dystrophic manifestations, the delayed dystrophic manifestations. The immediate dystrophic manifestation, you have got a called of a kind of a cinnamon which mimics a true arcus signalis, and the delayed dystrophic manifestations are in the form of keratoconus and keratoglavus. I want to ask Professor Sinha Saab, how many cases of keratoconus, this vernal PKH, you have seen keratoconus? Thank you.
There are many actually cases of VKCs. They do get keratoconus, secondary keratoconus. There are many cases, and but the only thing is that's why whenever a child comes with a VKC, we have to aggressively manage these cases, and we have to explain to the parents as well as the child not to rub the eyes, because that has been. And rubbing of eyes not only has a mechanical effect, but it is also an indicator that the child is having significant inflammation in the eye, significant evidence of VKC. So that is why it has to be aggressively treated. Otherwise, a large number of such cases will get keratoconus. So
Just
that
to
is
to add on to this, rather than in context with our topic for the course, how many do get keratoconus? Instead, how many of the keratoconus patients have allergy, and how should that be addressed would be of concern as related to the course topic, I guess.
yeah, that's true,
Because how many actually are being treated for keratoconus, and out of that, how many are having allergy. And how we take care for that is probably what would matter in relation to this
You see,
course.
the problem is that what I have seen in the past 30, 40 years is Kashmir is very common because of this allergy of the pollen and stuff like that. There's a self-medication of of steroids. They get the steroids a dramatic effect. And I've seen about 4 or 5 cases of conjunctivitis who have got a steroid-induced glaucoma, and they have lost their eyes. They got a glaucoma optic atrophy. They are on anti-glaucoma medication. So it's very important that they should not self-medicate themselves steroids. You have got now the proper modality of the treatment of our conjunctivitis. What I give is that I give, obviously, you have olopeptidine, you have cyclosporine, you have, and I have never in the present status given steroids. Okay, you can give mast cell inhibitors. There is a very good modality of mast cell inhibitors because we know that they will prevent the release of histamine from the mast cells, and it's basically a prophylactic. And the thing is that the mast cell inhibitors are not so much common. It should be used just at the start of the pollen grains. I've never in my practice given, because I've seen 4 or 5 young patients who have lost their eyes, even have undergone a trabeculectomy. The other severe cases of conjunctivitis, they get a vertebral plaque or shield ulcer. It's a very miserable condition.
Agree with you, sir, because if the patients don't follow up, then and they are using the steroid for a very long period, they may have complications. And use of cyclosporin, as you said, and also tacrolimus is something which is very effective in these cases. So if we have any doubt that the patient may not come for follow-up, in such cases, maybe we can resort to tacrolimus along with cyclosporin and avoid steroid. But yes, there are many cases which do require steroid, and we have to explain to the patient and the parents that regular follow-up is needed. I think a good chair time is what is very essential to manage these cases.
Professor Sinha, in our follow cases, how many cases of vernal plaques you have seen in VKH?
So I'd like to make a comment here. Whatever you are saying is absolutely correct. It is our duty whenever a patient of, because yeah, they are usually children, it's our duty to counsel their parents that there should not be any injudicious use of.
Yes, yes.
I work at PGI, which is a tertiary care center. We have referred from almost 6-7 states: Punjab, Haryana, Himachal, Uttarakhand, Bihar, Uttar Pradesh. And we see a lot of cases of secondary glaucoma as well as secondary cataract. And as you said, most of these cases are because of self-medication. Nobody told them how to use these steroid, and they keep, because they give them relief, so they keep on using these drops and end up. But besides that point, once they use it, then they usually don't end up in a keratoconus, because once they are not rubbing the eyes, but we see a lot of VKC patient having keratoconus also. As literature says, almost 40% of people with atopy are associated with keratoconus. No, which is a very high figure. And of course, the patient with the vernal corneal ulcer, though they are in periphery, and if treated again initially, they don't lead to much sort of many these cases are having keratoconus also. But if they get secondarily infected, we have seen many cases where vernal catarrh gets secondarily infected either with fungus because they are using steroid again, and or even bacterial. Then there is a very irregular astigmatism. I have personally done in maybe 10 cases anterior lamellar keratoplasty following infection and these vernal catarrh corneal ulcers, because the cornea become thin and irregular. And you have to prevent the vascularization in these cases, because if it happens, you are not able to do even a lamellar keratoplasty. So we have to be very careful with the children, and we have to counsel the parents of these children and use only soft steroid, which can be used for 1 year or 2 years altogether without having the side effect like loteprednol, low strength 0.2, and we have to have a pulse therapy, not to use dexamethasone or prednisolone, which people use right and left, and once they leave, they are from distant places, they keep on self-medicating themselves. So it's our duty to educate the public at large.
Last observation, Amjad Hussain Rahi, who was a oculoimmunopathologist in Morpheus Eye Hospital, has done a lot of work on vernal plaque. And his lot of articles are in the British Journal of Ophthalmology. One should go and listen to his Amjad Hussain Rahi, oculoimmunopathologist, an Indian basically with a British nationality who did MD from Ligad, and then he did MRCP path, oculoimmunopathologist. I have heard his lectures, he's a FRCS examiner, and he has done a lot of work on this vernal plaque. It's better to go through this British Journal of Ophthalmology to listen to read his vernal plaque, what he says. There are five, six
I
points.
would like to say the literature from India is much more than we have paper from North as well as South India, and we have to treat it early, scrape them, amniotic membrane, and judicious use of steroid. There are so many studies from Maharashtra, from LBPI, even from our center, PGI. So literature, I mean, we have contributed so much to the literature.
Thank you, sir. Thanks a lot for all the wonderful discussion and the presentations. I would like to thank all the presenters, Dr. Jagruti, Dr. Swapna, Dr. Vijay, Dr. Jain, sir, Dr. Namrata Sharma. And I would like to thank you all for participating in this IC and providing us some meaningful inputs so that we can improve further. So thank you once again for attending this IC. Thank you.